Good afternoon, everybody, and welcome to our workshop. I'd like to introduce myself. I'm Jim Campbell, University of Nebraska. I'm a general internist, now retired and working in clinical research. I'd like to introduce my co-presenters today, Dr. Kinhwa Fung of the National Library of Medicine, who will be reviewing our RxNorm ontology, and Dr. Stan Huff of Graphite Health, who will be talking about the exciting development of the LOINC extension, which he will be demoing today. I'd also like to thank Rory Davidson, Kai Cooley, Peter Williams of the tooling staff of SNOMED for the work they've done on preparing this. Without them, we couldn't have gotten started. And I also regret to say that Dr. Scott Campbell could not join us today. He was going to present the material on synoptic cancer, but problems at Nebraska required his presence, and so he sends his best wishes. And finally, our research development team at the University of Nebraska, Jim Svoboda, Stefan Frasima, have been a lot of help. Now, we're going to be demoing interactive material today. And all of this is something that you yourself can experiment with and work. And we strongly recommend that if you're interested in the use of the concept model in managing terminology questions, I think that you'll find that these are very instructive exercises that we have prepared. Now, our primary browser for this workshop has been prepared by Rory and the crew, and it has two extensions. It has the Nebraska Lexicon extension with about 65,000 RxNorm clinical drugs and ingredients. And it also has Stan's LOINC extension, which is in development, and Stan tells me that that will be available probably in March of next year. This will be available for a period of time after the workshop today for experimentation, but Rory and his crew will take it down. Now, there is an anylexicon.unmc.edu site, which has our browser year-round. So you can use that for reference and browsing if you wish. Now, the handout material which we're distributing and which is available on our website, github.com, Crane Workshop Seoul, has several reference materials. First of all, our use cases and the clinical phenotypes, that is the ECL queries for the exercises that we will be demoing. In addition, I turn your attention to documentation on RxNorm at the National Library of Medicine, and also LOINC at the Regenstrief website as well, because those are terminologies that we're actively looking at in this exercise. So our first agenda item today will be with Dr. Kinhwa Fung, and he is going to speak about the use of the RxNorm ontology. I would mention that he is joined by one of his staff members and colleague, Dr. Robert Nguyen, who is on the webinar and unfortunately could not be here in person today. And Kinhwa, would you like to come to the podium? Anybody need the handout material? Here you go, Kinhwa. Okay, you started from the beginning there. You can start it from the current slide right there.
Yeah, just the current would do, yeah. Hello, good afternoon. My name is Kim Ma Fong, and I'm from the U.S. National Library of Medicine. I'm doing a tag team presentation, as Jim said, with Rob Wynn. And by the way, Rob is the one who's doing all the hard work, and I'm just presenting the summary findings, a bit of background of what we're talking about. So first of all, a disclaimer is that the views that we express do not necessarily reflect those of the US government or NLM, right? And we have no conflicts of interest to declare. So this will be the outline of this part of our presentation. So I'll start off with an overview of RxNorm, what it is and what we use it for in the US. And then I'll talk about how we harmonize RxNorm and the SNOMED International Medicinal Product Model, and why we do it and how we do it, and some of the more challenges that we face. And then Rob will tell you a lot more in a lot more detail about the lessons learned that in this experiment that we try to use description logic methods to create an R version of RxNorm, which we call the RxNorm extension of SNOMED CT. And then finally, we'll be doing all together, at least people in this room, hopefully those who have computers with them, we can do a round of exercises of how we can use ECL to query the database of RxNorm that we have created specifically for this presentation. So next slide, please. So RxNorm is the national drug vocabulary for the US. So what it is basically just a normalized naming system to support semantic interoperability between computer systems when they want to exchange and handle drug information. So there are a few use cases that can use this kind of capability. For example, when you document in your electronic medical record the patient's allergy history, intolerances, you need a drug terminology that is interoperable across systems. In a formulary, you may need a drug terminology to keep track of your inventory of what is available in your, how come it's advancing on its own? Okay, I need to go back. Is it? I don't know why, okay. So the formulary is another use case. And then of course for e-prescribing, we need a way to transmit knowledge, information about drugs, from the prescriber to pharmacies and so on. And the RxNorm is developed by the US National Library of Medicine. And there are two parts of content in RxNorm. One part is publicly available, it's in the public domain. That part can be shared, used freely without any licensing. But the rest of RxNorm is coming from proprietary content. That means they can be coming from drug knowledge base vendors like First Data Bank, and they will need additional licensing for certain activities. For example, if you use them in patient data creation. So the scope of our RxNorm is that it will cover all the clinical drugs that are administered to patients with therapeutic or diagnostic intent. So for example, we focus on the injectable solution, but not something that the compounding pharmacy will use for dilution. So I don't know how to stop how come it is advancing itself.
I think you may be hitting the touchpad. Be careful not to.
I'm not touching anything, and it's advancing.
Really? Yeah. I didn't put any timing in it. Just go back to wherever you want.
Okay, you see, it advances. Should we open the other version of the? Maybe this version has a timing in it.
Okay, sure.
Let's try. This one, maybe this one. Okay.
This is the other one I got there.
Okay, sorry about that. Okay. The scope of RxNorm includes everything that is important clinically, right? Things that are prescribed for patients, either treatment or therapeutic or even prophylactic, intent. And out of scope in RxNorm is things that are like radiopharmaceuticals or contrast medium. For example, gallium is a radioactive substance that can be used in a scan to look for a metastatic carcinoma. And these kind of things are not within scope for RxNorm. Medical devices like pacemakers, they're not within scope. Food and dietary supplements are not within scope. And things that like bulk powders are things that are like laxatives or they're antacids that are, they're.
I'm going to turn off the touchpad. I think that's the source of our problem.
Yeah.
See if that fixes it.
Okay. So again, bulk powders are not included. They're like things of low potency, but they're like in powder form, and they're not usually involved in e-prescribing. So how do we use RxNorm in the US? So there are a few use cases, and according to the United States Core Data for Interoperability, USCDI version 5, the USCDI is a standard set of health data classes and data elements used nationwide in the US to facilitate interoperability. And in the USCDI, in this version 5, RxNorm is specified as the terminology to use for medications and also allergies and intolerance. In the Center for Medicare and Medicaid Services, CMS, RxNorm is used in the formulary reference file, and it's also used in the clinical quality measures value sets. The National Council for Prescription Drug Programs, NCPDP, they determines the standards for e-prescribing, which is in the scripts, SCRIPT, the script acronym, e-prescribing standard, and it's also specified in formulary and benefit standards as well. In the VA, the Veteran Affairs and the Department of Defense, they have different health systems, and they use RxNorm as a lingua franca to make sure that the drug information is interoperable. And last but not least, in HR 7, in the Consolidated Clinical Data Document, CCDA, and also in FHIR, some of the resources and data elements, they're specified for using RxNorm. So what is RxNorm? Basically, it's a drug terminology, right? So what does the terminology do? Basically, in any terminology, you can find three fundamental components of it, right? One is identifiers, like the SNOMED codes we are also familiar with, like the names, very specified name and preferred name, and then the relationships, of course. And RxNorm will provide a standard way to represent all these three things: identifiers, names, and relationships. So first of all, where do we get the data in RxNorm? So we did not create any of the data in RxNorm, but we import it from a number of systems. As I said earlier, there's a host of sources that are government and non-commercial sources, and there's another bunch of sources that are commercial sources, and then there are other medical terminologies that we are using. So the government sources, I will not read the list here. They include the FDA's structured product label for every drug, and they include even outside the US, Drug Bank as a resource, and the ATC, the Anatomical Therapeutic Chemical Classification System from WHO, and other sources as well. And from commercial sources, we've included First Data Bank, Multum, Micromedics, Gold Standard, and so on. And for terminologies, we have incorporated in content from MESH, the medical subject headings, and also from SNOMED CT as well. So what we do first is to normalize the identifiers, right? We make sure that the same entity has the same identifier. For example, in this case, acetaminophen, has different names in different systems, and they have different identifiers. So we all normalize that to this Rx CUI, what we call the RxNorm concept unique identifier, which is 161, right? That's the first thing about normalization of identifiers. The second thing we did in RxNorm is to normalize the names. So notice that in this case, all these 14, 15 ways of representing a certain drug, they actually refer to the same drug because it's the same ingredient, it's the same routes of administration, it's the same strength, but just that they are expressed in different ways. So in RxNorm, we make sure that they are all normalized to this form in a box. So just digoxin and then 0.025 milligram per mil injectable solution. So that is the name part that we are normalizing. And then we also normalize relationships because the clinical drug is one level, but then there are different levels of abstraction of representing drug-related entities. And in RxNorm, we call them term types. And the relationship between these term types are also normalized in RxNorm. So this looks very complicated, but it's not even the full graph representing everything in RxNorm. So the things that I've circled here in the red are the most important things. They are the clinical drug and also the branded drug. Notice that this diagram, the left side is the generic thing, and then the right side is a branded name. So they all have relationships linking them. So, but the most important part of RxNorm is the clinical drugs and the branded drugs. So these are what we call the dispensable entities, things that can actually be dispensed and prescribed to a patient. So as I mentioned, the SCD, the semantic clinical drug, will consist of three elements. First of all, the ingredient, the strength, and then the dose form. Like in this case, azithromycin, 250 milligrams oral tablet. The SBD, the semantic branded drug, is just the equivalent of it, but it's a branded form, so that's why we added in square bracket at the end. This is Cifromax, it's a brand name for the drug. So next I'll talk about the SNOMED International Medicinal Product Model and how we normalize it with the RxNorm model. So the SNOMED model, the goals of it are to facilitate international interoperability, for example, in cross-border care and in patient summaries, exchange, and so on. And the second use case of this drug model is to provide a foundation for countries to develop their own medicinal product terminology, such as by adding their own information about package, about branded drug information, like we have in RxNorm. The third use case would be to facilitate the pooling of data together from various sources to support clinical data analytics for research purposes. And last but not least is, of course, to support the development of medication decision support systems like allergy checking and duplicate therapy checking. So this is a graph that represents the entities in the SNOMED medicinal product model. So this is simpler than our RxNorm model. And again, the focus here should be on the green box here is the clinical drug. The clinical drug class is equivalent to the clinical drug in RxNorm. So basically it specifies the ingredient, the strength, and the route or the dose form. And notice here that it's again split into two parts. And then you can see the label there. One is the open world entities, and the second, the thing on the right is the closed world. That's why it's complicated, to understand this model. So I'll spend the next two slides explaining this difference. But by and large, from this slide, you can see that the clinical drug is the most important part, and it lives in the closed world entity part, right? And then the open world entity part includes the medicinal product or the medicinal product form. The medicinal product form is basically the ingredient plus the dose form and excluding the strength, right? So it's one level of abstraction higher from the clinical drug. Okay. So next, I'll talk briefly about why we need the split between the open world and the closed world view. SNOMED is constructed based on the open world view. That is, things that are not stated. I don't know how to make it stay. The things that are not stated can be true. For example, when you say that a medicinal product, I'm not touching anything, Jim. Yes, so I'm trying to keep my hand on that just so that I can go back and forth. Go out of presentation, okay, I'll try that.
Hit escape and it'll pop out to the presentation.
Okay, this is the presentation mode. And maximize it. So maybe easier, okay. Where?
Shrink the window so we can see it behind.
Okay, you drive then.
Oh. Presentation modes, you say, Stan?
That's what we use, the slideshow mode.
Okay.
It's okay to do like this.
Set up slideshow. Oh. Always use subtitles.
Use presenter view.
Use presenter view?
Oh, use timing.
Oh, okay.
Ah,
Oh, okay. Then don't touch other things.
Okay.
Just,
save that, and
And
we'll
from-
restart from this slide.
yeah. Okay. Okay, yes, I think I'm on this. So, okay, so SNOMED, the rest of the whole of SNOMED mostly, basically is constructed using the, it happens again.
Just go into out of presentation.
Okay, I'll just use the raw.
No,
This
go
one.
to go to this one.
Okay.
And then you can just advance your slides there.
Okay, I'll just use this. Okay. Sorry about that. So I hope this is large enough to see. Okay. Never mind. That's not the. Okay. So what is not stated in SNOMED, can still be true. For example, in a drug that which state in SNOMED that it contains X, it can contain other active ingredients. So that is what the open world view is. So we can also restrict it to more like a closed world view, but we have to implement something called existential restriction in description logic. No, sorry. Start again. So what is implemented now in SNOMED is we're using existential restriction. That means when we say that a drug has active ingredient X, that means that it has some active ingredient X. It's not excluding that it has other ingredients, right? So this is the open world view. But in other drug terminologies or drug standards, we have what we call the closed world view. That means, how come it's still advancing? That is very strange. Shall we close the presentation mode? Yeah, I think that's what's affecting it.
Presentation is not controlling it now, so just use your mouse and advance her.
Okay, let's see what happens. So in the standard that is the IDMP, or Identification of Medicinal Products standard, it requires a closed world view. That is, when we say that a medicinal product contains X, it cannot contain other active ingredients. So what is stated is false. So how can we bridge between the two views? So theoretically, SNOMED can switch between the two worldviews by implementing something called universal restriction. But it is not supported in the current flavor of description logic, which is EL++ used in SNOMED CT. And if we implement that, it will be computationally very expensive. It will take a long time to classify. And then there may be other knock-on effects as well. So Jim, this is happening again. This is very strange. I think we should close the presentation view.
That was still running?
Yes, this is still running.
It just hit escape now.
Yes, I've done that. Okay.
All right, that's probably why.
So the practical solution, short of implementing this universal restriction in SNOMED CT, is that we would try to mimic the closed worldview by two things. First of all, we would state that a certain drug, if it contains more than one, we'll clearly state how many ingredients it has. If we will say that by this active ingredient count attribute, we will say that it only has one active ingredient, and we've already stated that in the name, then it cannot contain other active ingredients. So that is one thing. And then to make this absolutely clear by the name, we would add the word only or precisely to the fully specified name, so that it's clear that, this is the closed worldview, and that what is not stated to be present in the drug is not present.
You can also, in the lower right-hand corner, while there's a up-down, you can use that to advance.
Okay. So why are we trying to do this harmonization between SNOMED and RxNorm, right? At least there are two purposes that can be served, right? The first one is very similar to what the SNOMED International Medicinal Product Model is doing. So it's to allow international interoperability of US drug information. For example, if you want to take a patient record from the US to other countries, and you can have, if you have a harmonized model, you can harmonize this information with things that are encoded in SNOMED CT. For example, to encode drug allergies and other things. And of course, data integration would be if you have drug information coming from different countries, and if you can put them together under the same logical model, it will be easier to analyze. The second motivation for doing this transformation of RxNorm into the SNOMED format is that we can leverage what is already in SNOMED CT as a common ontology to facilitate integration of different domains. For example, we can integrate diagnosis findings, procedures, lab tests, and medications together. Say, if you want to develop a patient care model or decision support system, then you can leverage all this information in different domains and use SNOMED as an overarching logical model to write your queries or your decision support rules. So this one, you have seen the two components of this slide. So on the left is the SNOMED model, on the right is the RxNorm model. So what we do is trying to align the clinical drug in the two models, because that is the most straightforward or that's the most useful probably level to align the two systems. So matching of clinical drugs is basically matching the attributes in SNOMED for clinical drugs and what is in RxNorm, right? So SNOMED CT has, at least these attributes about the clinical drugs, and RxNorm has ingredient, right? RxNorm ingredient would be matched to the precise active ingredient attribute and also the basis of strength material in SNOMED CT. Dose form in RxNorm will be mapped to dose form and unit of representation or presentation in SNOMED. And then strength will be matched to the way that the strength units and strength values in SNOMED to represent the strength of a drug. In RxNorm, we have other things which are not considered in this model. We have quantity factors is a 3 ml syringe that is not considered in this model. And qualitative distinctions like these are minute differences between different drugs. I mean, that can be important in some clinical situations, and is not considered part of this matching. So there are a few things, I mean, that we need to be careful about when we do the matching. First of all, in SNOMED, it is the drugs are represented in so-called presentation strength. So that means what it is basically what the patient can see on the box of the medicine, right? What it is, right? And it is not down to normalized strength. Remember the earlier slide I showed about different ways of representing digoxin 0.25 milligram per mil, and there can be a brand or a branded version of that same drug that says it's 50 microgram per 2 mil, right? Basically, it's the same concentration, but they represent different products. So SNOMED is representing the presentation strength, and they're not collapsed down to the normalized strength. So we can make sure that that is taken care of in the matching process. And of course, in SNOMED, the strengths are represented by different elements like the numerator, denominator, unit, and value. So that has to be taken care of too in this matching process. So base of strength material and active ingredient, a lot of the times they're the same thing, but sometimes they're not. So we have to make sure that we're matching to the correct ingredient in RxNorm. And dose form and unit of presentation, most of the time they are compatible, they are matched, but then there are cases in which we need to harmonize with some international standards to get the matching. So this is one example of the SNOMED model. This is a drug that is containing both amlodipine and also atorvastatin. And this is just to show how it's represented in SNOMED. And basically, it is a medicinal product, and it is a manufactured dose form of a conventional oral tablet. And it has 2 row groups because there are 2 active ingredients. And in each row group, you specify the active the active ingredient and also the basis of strength substance. And then you have 4 different attributes to represent the strength of each ingredient. So we have done some preliminary investigations, of how we can map between SNOMED and RxNorm. And our findings is that, this is a very high level summary. So it can be done, but then it's not straightforward. There's some there's some kinks that we have to straighten out before we can achieve more alignment. And specifically, if we talk about the 3 elements of a clinical drug, the ingredients usually give us the least problem because there's usually just minor disambiguation necessary. And strength gives us slightly more problem because there are different editorial conventions for units. And then, and as I mentioned, presentation strength versus the concentration or standardized strength can be a problem. And in dose form, we need more work to harmonize the 2 models. So one thing that I've not talked about so far is about drug classes, which are important things if you want to do queries based on drug classes. So in SNOMED CT, these are the way that drugs are classified or drug classes are constructed. So the first one is based on disposition, which is very similar to mechanism of action. For example, a product that's containing calcium channel blocker is a mechanism of action. The second type of classes is based on chemical structure, like a product containing aminoglycoside. And the third one is based on the intended site of administration, whether it's an oral drug, or whether it's a topical, or whether it's a parenteral dosage form. And the fourth one is based on therapeutic role, right? So there's been some change recently in SNOMED about how they represent therapeutic role. So SNOMED has decided that, they are only conserving or keeping those therapeutic role groupers that are intimately related to mechanism of action. For example, all products containing beta blocker, basically. So those are the things that they're keeping. But what they're removing or deleting is that the therapeutic role groups that are based on the use, clinical use, or based on the indication, more broadly speaking. Because the indication of a drug is dependent on the regulatory authority in a certain country. So what it can be used for is can be country specific. So what we're talking about is we no longer now have groupers like anti-lipemic agents or anticonvulsants or cardiovascular drugs. So these are going away. So this will have some implication on the users who used to use this kind of groupers for their work. So next, I'll turn to Rob to talk about the lessons we learned from creating this RxNorm extension. Rob? We can't hear you, Rob.
2 seconds came up.
Okay.
Hi everyone. Am I sharing my screen?
We're not yet seeing your screen, Rob.
Wait 1 moment. I cannot start sharing while the other participant is sharing.
Yes, it's happening.
Let's see.
Yeah. We can see you, but we cannot see your slides. Yes, we're seeing you now. Okay. We're seeing your slides, but yeah, I think you can carry on.
Do you see the full slide?
Yes.
Yes.
Okay. Good afternoon, everyone. My name is Robert Nguyen, a medical ontology research programmer with the National Library of Medicine. Today, I'm here to present lessons learned on creating a RxNorm extension of SNOMED CT. So, as Kinwal previously mentioned, in 2018, NLM proved the RxNorm and SNOMED IDMP are compatible. Both models are capable of defining a clinical drug made up of a dose form, strength, both units and values, basis of strength substance, and active ingredient. So what you're looking at here is a clinical drug for atorvastatin calcium 20 milligrams oral tablet. In the top left-hand corner is its label from Daily Med. RxNorm editors build the concept for the drug with these definitional features. They are also responsible for assigning it properties, codes, and attributes. One of those codes can be a SNOMED code. So in our browser, we link this code to the SNOMED browser. But of course, two browsers aren't great at proving interoperability. So they also don't tell you where issues might exist with the mapping. RxNorm shares definitional features with SNOMED CT sufficient to build similar classes in OWL. So with both the SNOMED CT and RxNorm drug product defined in OWL, we would expect a reasoner to find these classes equivalent. So we get a couple things out of doing this work. First, RxNorm, as mentioned, is a terminology, but not an ontology. And for those unfamiliar, what do I mean by this? RxNorm is completely flat. So it has drug products, but it doesn't contain classes necessary for classification, a hierarchy, if you will. So with classification, we get answers to more intelligent questions using subsumption, such as, I have a patient with an infection, but they are allergic to sulfonamides. What are all the antibiotics that do not contain a sulfonamide? We'll get to an example like this in our ECL exercises soon. But second, based on RxNorm assertions to SNOMED codes, we can also discover issues with existing mappings. We can also discover new clinical drug equivalences. So this is also an automated procedure to create new mappings. So here are our methods. Using the OWL API, we create logical definitions in OWL for each RxNorm generic product based on the IDMP. We then classify these definitions together with the OWL version of SNOMED CT using the ELK reasoner. After we collect these equivalences, the RxNorm drug products corresponding to the SNOMED CT drug products we're able to compare the inferred equivalences to asserted equivalences in RxNorm. So here is our example, atorvastatin 20 milligrams oral tablet built with a logical definition as viewed in the open source ontology browser Protege. After running the reasoner, ELK finds that the RxNorm SCD, semantic clinical drug, is equivalent to the SNOMED CT clinical drug. So note that we could also use the RxNorm ingredients to build these logical definitions as the classes to write the logical definition. Because RxNorm ingredients are added to the OWL file and they are made equivalent to their SNOMED clinical or to the SNOMED substances, where a code assertion exists in RxNorm. So so for instance, if in RxNorm we have acetaminophen as an ingredient, and in SNOMED CT we have paracetamol, both of those are equivalent in the OWL. So there is no difference between names, there's no difference between codes. These are mappings that the editors of RxNorm already provide, so these are our givens. Last year, NLM made the RxNorm and OWL pilot a public resource. It contains over 17,000 ingredients and over 17,000 generic clinical drugs. This is exclusive of PACs and branded drug products. They exist in their own namespace. This also includes all RxNorm properties represented as annotations. So you're getting NDCs with start and end dates, for example. This URL is probably too small to see from your seats, so I've included a QR code if you want to bookmark it. Users can download this experimental data set free of charge. All that's required is a UMLS license. Please sign up for that. Included with this download is also a README with all the prerequisites. So downloading this requires that you also generate the SNOMED OWL. That includes you needing to go out and fetch the SNOMED to OWL toolkit, freely available from the Itsudo GitHub, and loading these files into Protege. And you also need the ELK reasoner. Of course, if you also want to experiment with your favorite triple store and other semantic web technology, you're free to do so. This is just the data. And also, I would add, if you are just starting out with ontologies and you're a developer, go out and try the OWL API. It's really something. So here's an update on our work since last year. Of over 6,000 RxNorm products with asserted equivalents to SNOMED CT, 74% are inferred as equivalent to ELK based on the definitions that we generate for them. For the rest, there was one or more errors where the OWL definition prevented inferring an equivalence. And we observed these into the following types of errors, being ingredient issues, dose form issues, and strength issues. So I won't dig too much into the numbers, but ingredient issues are our biggest challenge. Different basis of strength substances, different active ingredients, and some overlap. Dose form issues are mainly with our injectables, and we have strength issues here and there, but this is mainly due to editing guide and rounding issues, and we don't see these very often. So this might be a little small to see, but here are 7 issue examples I've selected from the RxNorm to SNOMED CT assertions, preventing equivalences. On the very left-hand side, you'll see the RxNorm semantic clinical drug, and on the very right-hand side is the SNOMED CT clinical drug RxNorm asserts 2. The first 4 issues have to do with ingredient differences. For example, the first issue is a multiple drug product, amlodipine 10 milligram with atorvastatin 80 milligram. RxNorm has an active ingredient of atorvastatin calcium, while its SNOMED counterpart is logically defined with atorvastatin. Because of this difference, an equivalence can't be drawn after translation. The same is true for the following 3 issues with ingredients. So RxNorm may say timolol, but SNOMED says timolol maleate. Then we have BOS differences. The next two examples, we have esomeprazole sodium versus esomeprazole magnesium. And then we have hydrocortisone versus hydrocortisone sodium phosphate. The following, after that, after ingredients, we've got dose forms. Dose forms aren't simple to translate. So in order to map the correct dose form used by SNOMED CT that are based on the EDQM standards, the process aggregates all mappings for each RxNorm dose form. So take, for example, the RxNorm dose form oral tablet. So if RxNorm has 100 oral tablet assertions to SNOMED clinical drugs, and 85 of those map to a conventional release oral tablet, while 15 map to conventional release oral capsule, the process is going to configure all RxNorm oral tablets to use conventional release oral tablet on instantiation, i.e. there is no cheating allowed when generating these logical definitions. This is why we sometimes find issues with the injectables. So see, for example, the 5 milliliter zoldronic acid, 0.8 milligram over milliliter injection. The process is configured for all injections, the most popular manufactured dose form, powder for conventional release, solution for injection. But here we find an outlier. The SNOMED CT clinical drug is a conventional release solution for infusion. So similarly for RxNorm ophthalmic solution, we configure to the most popular manufactured dose form, conventional release eye drops, but this is not so for ketorolac tromethamine. SNOMED CT uses conventional release eye solution. So that's the dose forms. We've got a lot more that we can give examples for, but I'll proceed on. Last, we have an example of a strength issue. RxNorm may have a rounding error with 11.3 as the numerator value, while SNOMED CT is at 11.25. So what are our findings? The rate of translation from RxNorm products to SNOMED CT IDMP is encouraging at 74%, especially because OWL definitions for RxNorm products are generated completely automatically. However, the error analysis points to remaining issues. We classify them as ingredient issues, and those are generally reflect underlying issues in the description of drug products. For example, base ingredient versus salt selected as the BOS or active ingredient. The dose form issues highlight the difficulty of mapping dose forms across systems, particularly for injectables, and strength issues, including differences in the RxNorm and SNOMED CT editorial guidelines.
Are we taking questions as we go?
I'm sorry?
Okay, yeah, we can take questions.
I'm sorry, can we leave questions for the end?
Yeah, so this is Stan. So I understand sort of based on what you're dealing with exactly what the issues are. I guess the thing that's confusing to me is that these things represent real physical objects in the real world, and we ought to be able to figure out which thing is true and fix the other one.
Yeah, so I'm getting there. I'm getting there.
Okay.
Getting ahead of me. Okay, so this is where we get into quality assurance. So every mapping effort of RxNorm products in this IDMP offers an opportunity for QA. So assuming the mapping process is accurate, failure to infer an equivalence between an RxNorm product and its SNOMED CT equivalent may be due to an error in RxNorm or SNOMED CT, but less likely in both. So we found anecdotal evidence of such errors, and we report it to developers of RxNorm and sometimes the SNOMED CT, but we haven't gotten SNOMED CT to the table yet until we take care of our own data. And I can get into that a little bit more, but I'm not the expert. So I think, and this is just what I've been told, RxNorm relies a lot on daily med, whereas SNOMED relies on ECM. And I could be wrong about that, so someone more familiar with pharmacology can correct me there. But the ongoing harmonization in RxNorm has started this year. Lister Hill started working with the RxNorm editors on a harmonization process. The RxNorm editing team reviews issues for fixing as well as newly discovered equivalences to add as mappings. So this table is just a few examples of those that have been solved along with release dates on the left-hand side. And the second and third column are the drug products from each respective source. The last example demonstrates an ingredient issue for a non-US product where no fixes were made. And like I said, this harmonization is ongoing. So the limitations to this work is that we are limited to the fact that the model only covers drug products that are exclusive of branded drugs and packaging information. We're only doing this for generic drug products. Additionally, generic drugs in RxNorm with dose forms not found in SNOMED CT were not given logical definitions, but they are still represented as primitive classes in the OWL. Okay.
Right.
Any questions?
Any more questions for Rob? Yeah, this one, yeah, Stefan.
Yeah, am I right that SNOMED is more detailed when it comes to unit of presentation versus dose form, which often is the same, for instance, tablet, but in some cases it's different. And it seems that in RxNorm, the two things go together. Is it
Yeah.
true? And
Yes.
why?
So
Or
let
could
me
you
go
give an
back.
example?
Sure. So let's go back to this modeling of a torvastatin oral tablet. So when determining a dose form, we also look for the most popular unit of presentation because in RxNorm, we might say 20 milligrams as the numerator value, but then as the denominator value, we have 1 over each in RxNorm, 1 over each. So we need to say, okay, we're not using 1 over each, but the template requires a unit of presentation being tablet unit of presentation. That's also something that's configured along with the dose form. So where applicable, and this isn't for all products, because sometimes it might be over milliliter for the concentration templates. But we are paying attention to the unit of presentation. And as someone translating this from RxNorm, I cannot tell you why a certain unit of presentation is selected by SNOMED CT. But we're doing our best in order to translate to the correct unit of presentation as the denominator unit value.
And another question is about the BOS and the active moiety. Isn't this normally the same?
So there
Because
is
there
no,
was in one of the earlier slides, but I think it was during your presentation.
Not necessarily, because
Yeah.
sometimes the boss is just the active moiety. Sometimes the boss includes the salt form as well. So they're not always the same.
Okay. Mhm.
and there is no place in the template for an active moiety in SNOMED CT. There is for precise ingredient or active ingredient, as we call it in RxNorm, and and the boss, but we find no predicates for active moiety.
Okay. All right. Any other questions in the room? No. If not, then we'll move on. Thanks, Rob, but you should stay on, right, in case there are more questions for you.
Certainly.
Okay. Can we go back to the presentation? Okay. So next, we're going to do some.
You may need to share your screen.
Okay, share. PowerPoint presentation, okay. Jim, you better come out because it's not. I click share. And just exit here. There's the share there. Maybe share the screen is easier. Click share again.
Wait a minute, we want the Zoom. Do you, in the back of the room, do you have to share this screen or? Oh, here it is.
Oh, share screen.
There you go.
Okay, so next we're going to go through some ECL exercise. And the idea is that we'll pose the question, where are the slides for the, sorry, maybe in this one. Okay. So the first question is, how can we find all the antibacterial drugs available for oral use in SNOMED CT? So are people in the room going to try it? I mean, I don't see a lot of computers, but I mean, for the interest of time, we can show you the answer and explain it.
I think that with our pressure of time, maybe you want to go ahead and demonstrate that.
Okay.
I'll work on it themselves.
Okay, so this is our answer. If you're familiar with ECL, you know that, okay, this top part means that we are looking for all the descendants or including this concept itself of medicinal products in SNOMED. So because we are looking for clinical drugs, so this is the part that we should look at. And in order to look for clinical drugs that is available for, in order to look for antibacterial drugs, then we have to say that, first of all, how can we identify drugs that are used for as antibacterial agents, right? Because in SNOMED, there's this grouper that is based on the mechanism of action of the drug, which is substance with antibacterial mechanism of action. So we added this refinement. That means it has to have basis of strength substance, which is a descendant of this substance with antibacterial mechanism of action, right? So this part will give you all the antibacterial clinical drugs. And the next part is we want to find drugs that are available for oral use. So that means we need to look at another attribute, which is the manufactured dose form attribute, because this will give you all the drugs that are oral drugs dose forms. So all this together will give you all the drugs that you need. Let's make sure that it works. So we'll go to the browser.
These browser was a different one, right? Can you post the link again, or is it in the file?
It's in the file in the handout.
It's in the file in the handout.
Okay, so we need to go to, so on this browser, there are two data sets. We have to use the Nebraska extension for this exercise. Okay, and let's paste the query in here.
Now, wait a minute, before you execute it, hit the ECL builder, the blue box.
Yes, this actually,
Okay, here's the ECL builder construction of it, okay? And as Kinhwa said, we're looking for any medicinal product that has a basis of strength substance on something that's an antibiotic, and we're looking for a manufactured dose form of oral dose, any oral dose form, okay? And then if you scroll down, Kinhwa, you can finish up okay, and then you can go back and execute.
and then execute. So he will find all 1,864 concepts, including ciprofloxacin, fluoxetine, sparomycin, and all that, right? Yes.
I have a question. Oh, sorry.
The mic, Jim, the mic. Pass it to Stefan, please.
If I used has active ingredient instead of has basic what was base strength substance, basis of strength substance, wouldn't the result be the same?
Theoretically, in an ideal world it will be, but I tried that there is, in some cases, some differences. And we got tripped up by the fact that some of the ingredients, they're represented as salt form, some are not. And some are in RxNorm, but not in SNOMED, and some vice versa. So there can be some minor differences. So this actually, Stefan, you have a very good point here. So the underlying data is not 100% aligned at the ingredient level, particularly because of the BOS is not always the same as the active ingredient in the two systems. All right. So with that, I mean, so let's close this one. So the next example we want to show is, this is kind of the same, but then we want to show all the clinical drugs that is available for systemic administration. So, I mean, not particularly interesting because in medicine we say systemic is not just oral. We can inject, we can do other ways of, so in this case, we just add the parenteral dose form in our dose form as an OR. So we include all the injectables, right? So the next example is more interesting, in my opinion. So this is, we want to find the antibacterial eye drops. So what is different from the previous example or the previous question is that we want to use the has manufactured dose form, but this time we want to find the conventional release eye solutions, right? Instead of the oral dose forms. So this is how we change from oral dose forms to eye drops. So the next example is slightly, again, more complicated. So let's say we have a patient who needs to be put on an oral antibiotic, but the patient is allergic to sulfur antibiotics. So how can we exclude this sulfonamide from the list that is being retrieved, right? Any suggestions? Minus. Yes, just minus. Yeah, very good, Susan. But minus what? We have to find the sulfur antibiotics. So how do you do that? So we use the drug class based on structure, right? Because sulfur drugs is a kind of, it's a structure, structurally, the drugs will contain sulfur. So that's why we say that, this is the wrong, this one is the right answer. So we make use of this concept, which is, yes, which is sulfonamide substance, and we locate all the descendants of the sulfonamide substance. This is a grouper for all the substance that has this sulfonamide component in it. And that is what is causing the allergy. So, and then we use minus because we retrieve all the oral antibiotics and we minus all these sulfonamide drugs. So that's how we get the answer.
Basically, with ECL, you can use and for intersection, or for union, and minus
for the difference, yes.
Extraction.
Yes.
In set theory, that's what you call it.
Yes. So next we will explore a little bit on the strength part of the product. So let's say we want to find a drug with 10 milligrams of lisinopril, right? So you might be tricked into saying that, okay, maybe we can do this, right? The medicinal product has precise active ingredient, which is descendant or self of lisinopril. The numerator value is 10, and the presentation strength numerator unit is milligram. Of course, we have 10 milligram. So if we execute this, you'll find 12 concepts. Let's do this. I mean, this is kind of fun. Okay, it found 12 concepts, right? And if you browse through the list, you see, okay, they seem all right. Lisinopril 10 milligram, lisinopril 10 milligram, until you come to this concept. This one, amlodipine 10 milligram and lisinopril 20 milligram, right? So this is wrong, right? Because you're looking for drugs with 10 milligram of lisinopril, not of amlodipine, right? So what's wrong here is that because it's a compound drug and you have forgotten the row grouping, because the 10 milligram in this case applies to the other ingredient, but then the lisinopril is of another strength.
If you double click on that concept and bring up its definition.
Yeah, so this is the definition.
The 10 milligrams was relevant to the other ingredient.
Yes.
So you have to be careful with row grouping when you're looking for dose relationships and the like.
Yes. So to correct this, you have to add a row grouping. So this is a way to do it. I've highlighted the red curly brackets. That means that they have to be in the same row group. I mean, the active ingredient and the strength. So if you execute this, so you get 11 concepts, right? You don't, so the one that is wrong is now not on the list. So that is the secret for the row grouping. Okay, so I think I'm running a little bit over, so I'm going to jump to the final example, maybe, because I want to showcase the the use of this the dot notation, which is kind of a good way of it's a very useful way to find the attribute values, right, instead of the concepts. So let's say if you find, so you know beta blockers can be used in different ways, right? One is for hypertension, one is for the eye drop, right? But we want to find, okay, what are the routes of administration of all beta blockers? So the way to do that is actually through this very simple ECL query. So we find all the beta blocker containing products, and we put a dot, and then we put the attribute after it has manufactured dose form, right? Let's execute it to see. Okay, you will then retrieve all the values of that attribute, which is hence manufactured dose form, that are related to this group of products, the beta blockers. So here you can see that it can be used as an infusion form, conventional release oral tablet, eye drops, eye solutions, and all that. So basically, you show all the possible routes or forms that this beta blocker can be used. So I think I've come to the end of the examples. Jim, yes.
I think that we can plan to go ahead and issue the slide sets to everybody.
Okay.
At the end, if you're in agreement and Stan's in
Sure.
agreement. And then they can look through the remaining exercises, all of which have answers in the handouts.
Okay.
Okay?
So before I go, I should ask, are there any questions for me, and particularly, more importantly, for Rob, because it's now 1 o'clock, or almost 2 o'clock, I mean, in AM in the US. So, I mean, he will be very happy if he can go off to sleep. I mean, if there are no questions for him. Any other questions? Okay. Thanks, Rob, for staying up late. And I think you can sign off now if you want to.
Stan, you want to come up? You want to advance yours manually, or you want to?
Well, let's try full screen mode and see what happens.
There we go.
And are we going to break at 3? Or what's the plan?
Yeah, we've got 15 minutes, and then we have a 30-minute break.
Okay.
Okay.
Well, I should be able to get through my slides and then after the break, we can do the exercises.
Yeah, I mean, you've got a full hour, don't
Okay. All right. Well, we'll just get to where we get to then. So it's a pleasure to be here. I wanted to thank Jim for putting this together. It's a lot of he did a lot more work than I did to get this set up, and so I appreciate him doing that work. So a lot of the use cases that we're talking about really are to support clinical decision support. I know that's what motivates me a lot for being able to reason about these things ontologically, is so that we can put our knowledge into rules that then help people receive better health care. So I'm only going to just show a couple of slides. This is one. Number of studies have shown that there are a huge number of people who are dying of preventable medical errors in the U.S. This is a table that shows multiple studies that have been done, and down the right-hand side you can see the estimate of the number of people who are dying from preventable medical errors. And the lowest estimate is 134, and the highest estimate was 400 and something. And the authors of this article out of Johns Hopkins University estimated their estimate was 251. But that's an amazing number when you think about it. That would be, if you do a little bit of math and divide by 365, that's like 660 people a day are dying of preventable medical errors in the United States. And so a lot of my efforts, and in particular this kind of ontological representation of information, can cut into that. Will be a building block for things that we create to try and improve the way that we do things. So the other thing, unfortunately, is too that multiple studies have shown physicians do the right thing, order the right test or make the right diagnosis or do the right surgery roughly 50% of the time. So how does terminology fit into this? You think about the paradigm of reasoning and how the world works, if you will, around this kind of thing. And it all starts with things that somehow we observe or understand. And so we see colors, and we have visual intensity, and we have size and shape and perceptions of pain and heat and voltages that come off. And so it's either our senses or our extended senses. Extended meaning that we now have, devices that can detect wavelengths to represent colors, and we have voltages to represent sizes of cells that are passing through a micropore, etc. But those are all of those things. Basically, everything that we know starts out with those kind of things. And then what happens is that we turn that into, sort of primitive data, if you will. We say, well, based on the color and the visual intensity, I say this is red. Looking at the shape of things and sizes, I can say there's cervical lymphadenopathy. you know, I can measure an actual temperature. The pain I can say is a sore throat. From voltages on Coulter counters and things, I can say I've got a white blood count of 11.8, and looking at a culture plate, I can see beta hemolytic colonies that are growing there. So that now becomes primitive data. And then we apply a process, or an inference process in this case, and say, oh, that redness, cervical lymphadenopathy, we've got an inflammation process going on. The interpretation from the culture plate says this is a positive strep culture. We apply a rule to the temperature and say that's a fever. And then we say, oh, based on normal white blood counts, this is an increased white blood count. So we've now made sort of one level above the primitive data to say inflammation, fever, increased white count. And we add in other kind of, and then we can say all of that put together with a rule is acute streptococcal pharyngitis. And then the process there, you can continue, and you find out the patient had a splenectomy and some other things, and you go, oh, that all adds up now to this being not only a person with acute streptococcal pharyngitis, but they're immunocompromised. So that's the overall process. And the question is, how does the terminology fit into this? And attributed to Confucius is the beginning of wisdom is the ability to call things by their right names. And that's where the terminologies come in. LOINC and SNOMED are creating well-defined definitions for the elements that we then use in logic to create inferences, and then inferences on our inferences that result in advice and diagnoses and suggested treatments for patients. Now, there are two kinds of knowledge that I like to think about. One is textbook knowledge, which is a description of the pathogenesis of a disease. And so, for instance, for diabetes mellitus, what you're talking about is the fact that there's a relative lack of insulin. Either insulin isn't being appropriately produced, or the cells aren't responsive to the insulin in the normal way. And then you can get into all kinds of knowledge about insulin being secreted by the islet cells in the pancreas, et cetera. But that kind of knowledge is essential and important. But then when I talk about executable knowledge, and sometimes this would be called a computable phenotype, that textbook knowledge doesn't help me know whether the patient in front of me has diabetes or not. The way I know that they have diabetes is I do measurements on the patient that say, what their serum glucose was, or what their hemoglobin A1C is, or the fact that it takes insulin for them to have to be in the normal range for their glucose. And so that becomes executable knowledge now that I can use to take care of the patients. I can use that knowledge to know whether this patient that I'm taking care of has diabetes. And not only that, it can be the basis if I'm doing research. It can help me establish the requirements for the cohort of people who are participating in the clinical trial. So both are essential because the textbook knowledge leads us to do experiments and to understand and create greater knowledge of how things work. But the executable knowledge is the thing that I can apply in a real environment to help patients get better. So that's what LOINC does. That's what SNOMED does. We make those essential definitions of things that can then be used in clinical logic and to take better care of the patients. So to that end, we've created the SNOMED LOINC collaboration. And this is a continuation of an over 10-year relationship, formal relationship, and even going back to informal relationships. There have been informal relationships between LOINC and SNOMED going back over 20 years, but formal for at least 10 years. And the purpose was to combine the terminology in terminologies in a way that makes it easier to reason about clinical data. And so the things that we're looking for are that LOINC pathology content could be provided, and people who are using SNOMED as their primary terminology would be able to use those new terms in SNOMED to represent the data that they're using. LOINC gains a bunch from having an ontological representation of LOINC, so that you can reason about LOINC, and not only reason about LOINC, but reason about things that are mentioned in LOINC and use the relationships that exist in the SNOMED ontology. And we'll show that in some of the examples that we're going to go through. But that's a tremendous advantage in define and reason about the concepts across the two terminologies. And we wanted to leverage LOINC and the SNOMED CT subject matter expertise, and there's the thought that this creates a pattern also for how other things could be incorporated into SNOMED. And I'm thinking of genetic data or other kinds of data where the primary expertise is outside of SNOMED, but it provides tremendous value if you can combine the two kinds of knowledge together in an ontology and be able to reason about it. So having said that, the kind of things that we're thinking about then is that you can do against this, the new ontology would be to find all the tests that indicate active hepatitis of hepatitis B, or find all the tests for active Neisseria gonorrhea infection, both cultures and RNA and DNA and et cetera. Or find all the tests that can detect opioid use. They're used to monitor or also either detect it or monitor the use of opioids. Excuse me. So some details about the ontology. Eventually, all of the LOINC content will be in the SNOMED extension. We're working first on laboratory and specifically on quantitative laboratory, but eventually we will add clinical measurements, direct measurements on the patient, the document ontology concepts, imaging concepts, et cetera. So we're also aligning SNOMED concepts with LOINC, meaning that there are already existing observables in SNOMED, and we want to find those concepts and represent them in LOINC so that we have consistent and uniform representation of all of the concepts that are shared between the two terminologies. In terms of our process, the way this works is that we take LOINC parts and we find them and map them to concepts in SNOMED. And once we have a mapping, then we can position those concepts into the machine-readable concept model, the observables machine-readable concept model within SNOMED. And that becomes the representation in SNOMED. And Jim Case stresses the point that this isn't a mapping. What it is two different representations for exactly the same concept. Because of the mapping of the LOINC parts, the representation of the full LOINC code has exactly the same meaning in SNOMED as it does in LOINC. And it just allows, basically what we're doing is providing two different identifiers for the same meaning, a LOINC code and a SNOMED code for those things. We're initially not creating grouper codes in the SNOMED extension because we want to use ECL to basically allow people to find everything they want to find. We're thinking about that. I say that because as you go in and as we look, for instance, you look up observable entity now in the new prototype extension, and it says, 10,000 children. So that's a little, some people might want to see a little more, a little more separation of the data in the ontology. And so you'll see also when we get into looking at the examples, working on the exercises, that the LOINC code is displayed as part of the information that is displayed for the SNOMED concept. And then a decision that we made early on is to create the fully specified names for these concepts in SNOMED in the extension, to be consistent with the way that the fully specified names are created in the international edition, so that if and when these concepts are promoted to the international edition, they would have the correct fully specified name and wouldn't require changes in the way that the name is created. So those are some things. It's been a great collaboration. You created an automated transformation of the LOINC codes to the SNOMED representation. We've really had a nice division of labor, that the content is really coming from LOINC, and then the knowledge of the ontological representation comes from SNOMED, and we have a lot of discussions between the two groups to understand the best representation and how to do it. And then find out that there are complementary skills between the two different organizations in terms of not only the real world knowledge, but their specific knowledge about this kind of observable data, and also just about all the software surrounding these kind of things in terms of browsers and databases and all kinds of things. And so it's been a great collaboration. So we had a prior pre-release of 23,840 concepts, and we've gotten some good feedback based on that. And we, since then, have continued to work to improve things that we did poorly in that first release, first pre-release, I should say. But you can still find that and browse it at the loincsnomed.org website. But what's coming up, though, is the first formal release of the LOINC ontology, which will be based on LOINC release 2.79, which is due in February of 2025. And then when we do that release, then there'll be we're planning for a joint webinar between the two groups. We've grown the actual content by 10,000. Whoa. The ghost is back. So we have over 33,000 concepts now, mostly quantitative labs. We took special effort to find and make sure that we had mapped the top 200 most used LOINC concepts, and that covering those top 200 actually covers somewhere above 80% of all of the actual volume of data, lab data, that's flowing in the world today. So it includes panels, but the panels don't show the contents of the panels right now. But what we did do is make sure that we didn't put any panel names in where the elements were not defined also as part of the extension. So the groups that are there, their members are there, but the association hasn't been made between the name of the panel and the things that are members of the panel. So when I'm talking about panels, just to be clear, I'm talking about things like Chem7s that contain a sodium, potassium, chloride, glucose, etc. measurements, and other kinds of panels like liver panels and all of those kind of things. And then yeah, all of those, but all of those panels and lipid panels and other things are there, but they don't have the the link to the actual members. So this is a good time to stop because, yeah, now this is where we get into exercises. So let's take the 30-minute break and reconvene. And yeah, we'll see you back in 30 minutes. Oh, good. So we could fix that right here, right?
Actually, I don't think you can do it in the builder, Stan. I think you'd have to do that in the window and edit it in.
Oh,
Text is the best way.
because,
The builder is not infinitely variable.
but what's different about it? It's not a, it's a,
I mean, we can ask Kai whether they've added the feature, but a year ago, I know they weren't supporting that when you were nesting a set of values. You know, the ones to the right-hand side. The left-hand side is the attribute, the right-hand side is the value.
right.
And,
But it's not a simple and of that other class?
you could do it. You could do it that way too, as 3 ECLs with an or between them.
Yeah, that's
And
right.
that would be the union of all of those.
That's what I did.
Yeah, that's fine.
Okay.
And if you choose here the first and then you add the other ones with or, then what does or bind more closely than and?
Well, we could put it in there, and then I think all we'd have to do is put a parentheses around the guys, right?
The question is without parentheses, which is a priority of the operator? Not or.
So, I don't know.
We'd have to consult Kai.
I think they actually would force you, I think it would just get confused. I think you have to use the parentheses to tell it how to group things. That's what I would guess based on my experience.
And I think that's why we had trouble before adding another and
Yeah.
to a series of ors.
Oh, yeah. That would be true. So, let's go back and then let's see here. So again, we can execute this guy and now we get 85 concepts of, so, you know, I mean, there's we're focusing on the syntax, but the wonderful thing that happened there is that SNOMED knows a whole bunch of things that have opioid receptors. And then we can take advantage of that knowledge and look for lab tests that have, you know, all of those substances as the component of the test. And so that's what you get, because if you're just working with LOINC itself, you don't have that knowledge of what things are opioids. All you have is the names of the compounds themselves. And so I don't want the forest to get lost by looking for the trees here. So the fun one that I was working on, so, you know, this basically is looking for all observables where the component is an entity. But then what I wanted to do is I wanted to figure out how to do a query where I could find all of the lab tests that pertain to sexually transmitted diseases. And so here I have three ways that you can get all of the organisms of the sexually transmitted diseases. So we'll just take one of these. And let's see. Oh, not copy here. How come that's copy? But what I found is that I can waste like 3 or 4 hours trying to get a query right. You guys are, I'm sure, would be smarter than me about that, but. Whoops. Whoops, 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 whoops.
You're gonna have to erase that one.
Oh, yeah, the one. I shouldn't have put that one in there, yeah. So you get 15 concepts here. But what you'll notice, for instance, is that there are a couple of things in here that I didn't want, and I'm not positive why they're here. And one of you smart people could probably tell me. But in the query, what it's doing, let's look at the query up here again. You're picking up sexually transmitted infectious disease disorder, and then what you're doing is traversing the causative agent link there. And as I got more experience with this, you needed to not only say causative agent, but you needed to say it's also an organism. So it's a causative agent, but the thing that you found is also an organism, because there can be causative agents for causative things that are not organisms, apparently. But I don't know, what these are. This is basically the whole, all bacteria and all viruses. And so when you go to the next phase, for instance, and then I'll go back over here. Yeah.
It's probably due to some poorly defined SNOMED. I mean, not everything is perfect. And you could answer your question just with an ECL where you're looking for any sexually transmitted disease, and instead of a component of less than or equal, you say equal. And you want precisely the bacterial genus as the value, and you'll get those.
Okay. I actually got it working, and I didn't know how to do that. So, yeah.
I think it's okay because there's a concept, sexually transmitted bacterial disease affecting skin. This means that has bacteria as target concept. Therefore, it's right.
Oh.
Venereal disease is pregnancy.
Well, I wanted all of the fun ones, not any of those boring cutaneous guys. Anyway. Well, yeah, the way I solved it was not the smart way, but what I did is put in a minus that said take out the viruses and the bacterias, and that solved it. The other, but I mean the interesting part of it, and I'm sorry I don't have the query here, is what you're doing now is once you have that the query or the ECL statement that gets all of the things that you wanted, Neisseria, gonorrhea, and syphilis, and all those guys. Then you say, I want the laboratory diseases, I want the laboratory observations where those things are the value of the component. And so now you've got a parentheses and an equal sign to be able to stick that statement in as the value of the component in the ECL. I have that. What I'll do is email, I don't know, I can email it, and then you guys, or what I'll do is put it in this file and resend this whole file.
Can I share? Show you something that's also weird.
Yeah, I'll stop sharing.
Yeah, so I have an unexpected result here. Hold on. I'm loaded as just a regular visitor. It doesn't look like I get to share.
Oh,
Is there a way to,
Do we have on screen the ability to give somebody the ability to share?
well, I thought,
yeah, can you promote me?
We can't give him a chance to share a screen?
this
Can
is
you
one.
promote me? Is there
No.
anybody else even in Zoom? Yeah, Rob.
I'd be careful giving him any superpowers.
There we go. All right, so let me share. Share. Okay, so
There you go.
I gotta get all this stuff out of the way now. So here's my query. So as I said, these are the, the ones, boy, it's small, isn't it? Let me make it
But in the
bigger.
past, if you tried to use the blue button, Rob, and promote that up to the builder so you could see what it looks like there.
Yeah, it
It
breaks
won't
it.
do it.
Yeah, it breaks
And
it.
that's because the ECL builder won't support that logic.
Yeah, it's breaking it. So what's interesting, so this one is, that has component, right? Do I have the one that's got component? No, this has the parentheses in it. See right here? So it's component, and then it has the 3 types of substances, right?
Yeah.
And you get 196 concepts. Now, let me go
Good job, Rob.
get the, let me go get the.
For an A in the class, huh?
Yeah, I'm going for an A. So, okay, so now this one is an ECL that breaks it out with component 3 times, right? So component equals or component equals, right? No other difference. Exactly the same thing. Execute 183 concepts. Do we have any idea why that might be true?
You don't have the parentheses.
I know, that's the point, is that I have, this one is doing
It's
unnested.
undoubtedly, the ECL processor is not understanding exactly what you're after.
But it's the same thing we've done at other
No,
places.
you didn't have the parentheses, you don't have the parentheses in.
Right, but it's just saying component this, or component that, or component. Unless, maybe it's actually taking that last component and putting those 2 together, right?
Don't know.
That might be,
And we're running behind time, Rob, so I'm
well,
gonna close you down.
all right.
So, yeah, so that's all I had. And what I would just say is that as you can tell, some of you are probably much more expert at the ECL than I am. But I'm excited to be able to see and take advantage in the LOINC extension, the relationships and information and knowledge that exists in SNOMED. That's a very, very powerful thing, and that's what I hope you can remember on that.
Let me ask a question, more general question.
Wait a minute. Need a microphone?
Let me ask you a more general question regarding the further evolution of this embedding of LOINC within SNOMED, because so far there is the recommendation to use measurement procedure concepts to fill the gap. In the future. Okay. Yeah, but for instance, that we don't have an observable glucose measurement, glucose in blood, and therefore, instead of using that observable, there at least is the alternative or the workaround using a measurement procedure or glucose in blood measuring procedure. Yeah. So in the future, both possibilities will coexist, I suppose. Or will the measurement procedure concepts be retired? Or if not, will they be linked
I think they're,
to the LOINC codes, or perhaps probably better the LOINC concept, because there will be several LOINC concepts for glucose measurement, because there are different kinds of techniques and so. Will these be linked back to these procedure concepts?
so I don't know. I mean, that's the kind of thing that we need, and that really isn't so much me as it is it's the existing editorial policies that you have. And I know there's been a long discussion about procedures versus observables and that sort of stuff. And so, yeah, I don't know, Stefan. I don't know.
I think it's fair to say it's on nobody's work plan right now.
Yeah. So I mean, I think that's resolvable. And it really, I mean, there's a couple of issues to consider. I guess I should still be on the microphone. There are a couple, there are the issues there because, from a purist point of view, there's the procedures, and then observables, at least in the way we use them, is really representing the result of that procedure, not the procedure itself. And you can tie those together, but there's also just a philosophical thing that has to do with containment and context. In other words, basically you can think about the concept that says, glucose mass concentration, whatever, as usable as an orderable item or as a resulting item. And if you put it in an order, what you're really saying is, this is the name of the procedure I want you to do. And if it's in a result record, it's saying, this is what resulted from that. But, whether you want, the style has been, or I guess there have been arguments, at least discussions, no, we would never argue, but discussions, about using the procedure as essentially in context, like it was an observable and vice versa. And I
think what is probably ontologically safe, to put it that way, is that the result, that means the observable, implies the existence of the procedure, because
right.
It's not really, it does not exist without the execution of a procedure. And therefore, having it as an additional attribute or additional constraint, I think this would establish the link, and it would not cause any side effect, I would say.
Wouldn't hurt anything that we're already doing.
But it may help linking records which are which encode measurements in different styles.
That's not up to me. Thank goodness. Anyway, sorry to be overtime.
No problem, Stan. I think what you were discussing is very important material. So I want to spend the last half hour talking about a new body of material in SNOMED and giving you some thoughts about how that new SNOMED content may be useful by exploring its concept model. This is all is the result of the work by the Cancer Synoptic Result Group. And I want to give them recognition, along with Scott Campbell, who chaired the effort, for 4 to 5 years of intensive work with a bunch of domain experts in pathology that brought it about. I'd like to start off just by explaining briefly what is a synoptic report. Throughout the world, basically you cannot report legally a diagnosis of cancer, okay, without a pathologist doing a microscopic examination of tissue that was removed from the patient. Now, with things like lymphomas and leukemias, it's not exactly tissue, but you get the idea that a microscopic exam by the pathologist is necessary for the diagnosis. Now, for many years in the United States, I should say in North America, the College of American Pathologists issued protocols for what observations the pathologist should make about a cancer case. And because cancer is very complicated, multi-genetic in nature, there are a number of protocols depending on the types and the origins of the cancer, okay? Colon cancer is treated differently than breast cancer in terms of staging and identification of the cancer types, et cetera. Historically, this is the way the pathologist would record their findings, okay? It's basically a series of questions. Where was the tumor site? And then they would check off the anatomic position of the tumor site. There was information about the specimen as it was obtained from the surgeon, because sometimes they're broken up in pretty sad shape. Other times, they're quite acceptable. Size of the polyp, because this is colon cancer, et cetera, et cetera. About 5 years ago, work at Nebraska started with the College of American Pathologists to organize the capture and the structured SNOMED encoding of these questions. The tumor site, what was the tumor site? That progressed and eventually came to the attention of a number of other SNOMED member countries who agreed with a project to basically move this into SNOMED International once the material was vetted. And that vetted included going to the International Committee for Cancer Registrars and working with the international group, other member countries, to be sure that it fit with their standards. Now, in the handout material that I distributed, the SNOMED CT Clinical Implementation Guide for Cancer Synoptic Reporting, gives you information if your site is looking to use this in ways that is supporting their own pathologist workflows, because there has evolved electronic reporting by the pathologist to replace the check sheet formatting that was done before, so that basically the results from the pathologist can go directly into our electronic health record. Now, the scope of the synoptic report includes, as I mentioned, information about the specimen, the tumor, the margins. I'll explain what a margin is in a little bit, whether the regional lymph nodes were involved in the cancer. This has to do with the spread or the potential for spread of the tumor and the staging. Now, I would caution you to be aware that there are elements in the synoptic reports today that have not yet made it into this body of work. And that includes the tumor genetics, which is obviously an evolving area and is not in use by all sites, as well as fluorescent in situ hybridization, a technique for biomarker detection, and biomarkers that are based on genetics. In the future, central nervous system cancers, leukemias, and lymphomas will also be added by agreement with SNOMED. That work just hasn't been done yet. So think of this body of work basically as a whole long series of questions, okay? Because that's what it is. The pathologist was answering these items. So it's obvious to us when we began to analyze the semantics, this was virtually all observables, okay? A type of clinical observable that hadn't been done before. And when I asked Dan Vreeman why it wasn't in LOINC, it was because the College of American Pathologists never agreed to the collaborative work as they did with us. The use of the observables, I'm going to discuss, or the structure of the observables and how you can use the concept model, I'm going to discuss some details. But the attributes that are employed, one that Stan didn't show us is adheres in. And that's basically the attribute which points to, it's called the what is it, Stefan? It's basic, yeah, but it's basically the something continuant, independent continuant, something that exists in time and space, you know, and has an existence, I guess, that is included. Okay, otherwise, direct site, property, component, you've seen. Relative to is used for denominators when those are necessary. Scale type, technique, time aspect, Stan referred to all of those. But something that he didn't refer to are the characterizes attribute, which is related, which is involved when we're describing a process rather than a component that is a physical thing in the system. And process extends to, which is used for identifying metastatic cancer sites, is new. So those are basically new features. Now, in terms of the scope of all of this, it is, as I say, a lot of work. And it basically points to the case of what are the observations made by the pathologist about this primary tumor. I mean, they're the only ones who ever actually see the primary cancer, okay? Because once it's removed, you know, their observations are the point of origin, if you will. And there are such things as secondary cancers, which are metastatic spread or direct invasion. We know that tumors grow, and we'll discuss those in a little bit in a second. But I want to start off by discussing a use case in clinical research that I have encountered many times that uses the synoptic data. The cancer registrar is asking how many cases of primary colon cancer of the rectum having size of greater than 3 centimeters. Size of the tumor obviously makes a difference as far as its stage, were diagnosed last year. So the point I would want to make on this is that when you compare this to the question answer data that's coming out of the synoptic report, this is actually 2 questions, okay? What's the site of the tumor? Where is it located, okay? And in this case, they want to restrict it to the rectum. And what is the greatest tumor dimension? 2 pieces of data, both of which are in the synoptic reports. And if we take a look at this query, I'm switching back to the browser, and I'm changing it over to the Nebraska extension, although this material should be in the LOINC extension database as well. And this, I just wanted to explain a little bit about the construction of this, okay? So basically, we're looking at an observable, basically looking for a piece of data about, and here's in, a malignant neoplasm, okay? The direct site, and Stan, one of the things that, you know, in the clinical chemistry, the direct site and what is normally, I consider the system to be adheres in, okay? You know, they're indistinguishable, okay? But in this particular case, we're looking at a malignant neoplasm that was removed from the patient, surgically excised, okay? And it also has a feature that this observation characterizes the malignant proliferation process of the neoplasm. Why is that important? This is the way that the model describes a primary neoplasm. If you think about it, the pathologist is the only one who ever sees the primary neoplasm, okay, microscopically. An observable that adheres in a malignant neoplasm characterizes the malignant proliferation process and is in a surgical excision specimen, is an excised primary cancer that was examined by the pathologist. Now, what we're asking for is the site of the tumor. And for that, in order to describe that or to identify that type of information, we go and define the property, okay, of anatomic location property, all right? This is a new property that was added for anatomic pathology, all right? Basically, I did an examination of this tissue, and the tissue came from X, Y, or Z, okay? And in this particular case, we're looking for those where the anatomic location was the rectum, all right? So back to the construction of our, I'm sorry, I need to execute that. So this is an observable which basically looks for the anatomic locations of the primary cancers, okay? And if we look at, and there's lots of pieces of the cancer or cancers in the specimen, you know. There may be something at the margin. There may be, you know, this is relative to cases of malignant melanoma, et cetera. As we go down through this list and look for site observables, okay, basically we come across this observable, anatomic location of the excised primary malignant neoplasm. So thinking back to our use case of how we find these cases in our database, remember, we're going to search for two pieces of data. One will be that the anatomic location of the excised primary malignant neoplasm is rectum structure, or a descendant of rectum structure, but I don't believe there's any children. Okay, whoops. Okay, and then the second item is we're looking for tumor dimensions of greater than or equal to 3 centimeters. And here's this is the handout material. And I'm just pulling up the dimensions of surgically excised primary neoplasms. And in this particular case, you see the other attributes that I talked about before. We're looking at a malignant neoplasm that was basically surgically excised, and it's a primary neoplasm. What we're looking for in terms of the report, though, now is a property of a length. Okay, so we're measuring a distance between 2 points. And literally the pathologist is looking at the tumor microscopically, identifying one border, identifying the other border, and measuring the distance between the two. And that is what goes in as an answer to this particular question. So that is a ECL that basically looks for length properties. When we execute that, we see that over the space of the numerous synoptic reports that they have already completed, we've got a number of dimensions. I mean, there's 3 dimensions basically in every tumor size. And what we're interested in is the greatest dimension is greater than or equal to 3 centimeters. We pick and we're looking at something which is in the rectum. Okay, so we choose the appropriate observable. And what I talked about earlier in terms of the rectal tumors that were greater than or equal to 3 centimeters, 2 queries of our database, okay, anatomic location of the rectum and greatest length greater than or equal to 3 centimeters. That's a quantitative observable, okay, so it returns a number and a set of units. And the point I want to make is that if you're implementing the synoptic data sets at your site, these data need to be linked because these observations are all in the context of that report, okay? Depending upon the vendor and how they're organizing things, they may use the case ID in some external index. They may use an encounter ID, or they may use an order ID to link them all together, because the pathology report is typically ordered when the clinician sends that specimen in. But this is 2 classes of observables, and the anatomic location property and the length property are two that I want you to be aware of. The administrator of your cancer registry is asking how many breast cancer cases were diagnosed in the past year that were estrogen receptor positive. Now, this is one of a number of bits of data that are called biomarkers, okay? And they're basically protein units, or in some cases, nucleic acid fragments or other things that are metabolic byproducts of tumor metabolism that are important in understanding their treatment or their aggressiveness or a variety of other clinical features. And there's quite a bit of this material in the synoptic case reports. In terms of the answering this particular question, I'd like to take a quick look at that ECL, because it'll bring up an old friend of yours, Stan, the component. So you can see in this case, we're basically looking at a malignant neoplasm, but we're using the inherent location attribute to define this as a malignant neoplasm that originated in the breast, okay? And it has a component which is basically, in this case, a protein fragment, but it's basically a thing that was found within that malignant neoplasm. And when we run that executable, you can see we've basically got two particular findings, which the pathologist reports by protocol, whether or not there was estrogen receptor activity present, and then secondly, how intense was the staining, because this is an immunofluorescent stain technique that is used to report this. Now, a related question, something that you can explore yourself afterwards, is, okay, what are the various tumor markers that are available, that are used in the synoptic reports? My cursor is disappearing. So as far as the previous is concerned, okay, the question here is the presence of estrogen receptor in the primary malignant neoplasm of the breast. And the answer that we'd be looking for would be positive, because this is an observable with a nominal result, okay? If you want to see what other types of biomarkers that are found in the synoptic material, you can basically search, perform this ECL, and notice that I use the the dot formalism that Stan demonstrated to you earlier. And I just look for all the values that are fulfilling the component attribute, okay? So estrogen receptor was the one we looked at here, but if you look through the rest of the material, progesterone receptors, HER2, are both in breast cancer, Ki67, programmed cell death ligand, a lot of technical biomarkers that are in use in cancer medicine, and frankly are important data for cancer researchers. Let's talk briefly about surgical margins. A thoracic surgeon wants to study his cases from lung resection, and asking for all cases that had malignancy involving the margins. Now, what is a margin? When a surgeon cuts a tumor out of a patient, their cut surface on the tumor basically defines an anatomic location, which is called the margin, okay? It's the boundary between what was in the specimen and what's still left in the patient. And if you think about it for a second, if there's tumor that is seen microscopically in that margin, that's a bad thing, because that means that there is still cancer in the patient. So the thoracic surgeon is looking for all of his resections that, were not optimal. And if we go ahead and explore this particular query, okay. So here's another example of the use of adheres in, where we're basically looking not at the malignant neoplasm, but at the margin. That's valid as adheres in because it's an anatomical entity that was basically created by that cut surface, okay? And we're looking for surgical margins that have a component of a malignant neoplasm. We're looking for the property of the presence. In other words, was it there or not? So let's see what we get when we execute this. Okay, presence of malignancy at the surgical parenchymal margin in the excised lung specimen. Okay, that looks promising for the thoracic surgeon's case. And you can see there's others from lung, and there's also from skin. The thing is that margins are defined differently by every bit of anatomy, okay? When you cut at something from the skin, there are different cut margins that you have to name. So the question that we particularly want to use to answer this question is basically what we saw there, looking at the adheres in the margins, property of presence, component of malignant neoplasm, but a direct site of a specimen from the lung. So that'll narrow that bigger list down just to those that were done on lung specimens. Your cancer registrar is asking for an inventory of colon cancer cases by last year by histologic type. I don't think we need to belabor this, but there's basically a new property of histologic type that was created specifically for the pathological examinations. And so basically the question in this particular case is going to be this. You're going to query your database for that. And the answer in this case is nominal, and it's a series of morphologic abnormalities like adenocarcinoma and adenoma, et cetera, et cetera, et cetera. All basically, well, I should mention that Scott tells me that there's a lot of work in terms of reconciling and coordinating the classification of histologic type with ICDO, and that work is in process. Cancer Committee wants to review surgical cases where vascular invasion was involved. What time have we got? 4:53. Okay. I'm just going to whiz through these because we're running short of time and I'm detecting the bleary-eyed stares. So let's just say that invasion is obviously something that is important in observations, okay? There is a well-described formalism for how that is modeled in the synoptic reports. And so this is the question, and we'd be looking for presence of the present as an answer in this question, which is basically, was there lymphovascular invasion found in the excised specimen? Positive lymph nodes. I think it's understandable that if cancer has traveled to the regional lymph nodes, that's a big deal. And so there's a whole series of observables on the lymph nodes that may have been found with metastatic cancer. And the last item that is present in the body of work is pathologic stage. And I don't know if you've seen clinical cancer staging. It's called the TNM classification for tumor size, nodes, positive or negative, and metastases, okay? And it's defined a bit differently for every cancer type by, I'm not sure what's the agency that, it's WHO, Stan, that?
In the US, it's AJCC.
Okay. Anyway, the TNM staging is something that the pathologist reports on as a part of their exam, okay? And again, it's specific for various types of tumors, but if you take a look at the observables, pathologic stage, and clinical staging is done by the clinical oncologist after they receive the path report, and then they incorporate additional information that the pathologist may not have, like the lung x-rays and the CAT scan of the head, et cetera, et cetera. And I think that is enough for today. Okay? Any questions about the synoptic material? I guess I just want to emphasize from the standpoint of in praise of the pathology group, the work reporting group, that they did a lot of work on this, and it's really important for cancer research and so. Any questions or any questions for any of our presenters? Stefan? Stefan, you want to grab the mic?
Because you just mentioned these tumor stages, TNM, and so there are really two standards body which are not completely the same, because either the UICC...
I think there are several, Stan, use the mic.
So I might say the initial's not quite right, but the basically outside of the US, the TNM staging stuff is done by ICCR, I think, something like International Cancer something. And
Cancer registrars.
Registrars, you're exactly right. And then in the US, it's AJCC, which is the American Joint Cancer Committee or Committee on Cancer, one or the other, which is actually an activity organized by the American College of Surgeons. So, yeah.
Does that answer your question, Stefan?
Let me just ask, but mostly the criteria and the stages are the same, or?
Very, very close, like 95%.
Okay, yeah. Yeah, and that means that so far in SNOMED CT, there's only the American system. The opposite.
The system is proprietary, and they weren't able to get a license agreement with AJCC.
But I've just looked up and